Hello friends, I'm Dr. R.K. Marya. I'm a practicing physician and diabetologist in Hauskas area of South Delhi. I'm attached as a consultant diabetologist at National Heart Institute in East of Kailash and also have my diabetes clinic in Hauskas. So today we are going to talk about a young patient, Mr. A.V., who is about 58 years old, uh, who has diabetes for the last 4 years. He's also obese, he's hypertensive, he has got hyperlipidemia and obstructive sleep apnea as well. And BMI is about 32 kg per meter square. His blood pressure is 130/82 and heart rate about 60 per minute. His A1c shows it is around 8.3%. EGFR is 70 ml. His LDL, HDL is now under control. LDL is 69. Triglycerides are 250. His liver enzymes are a little raised with the AST and ALT of 70 and 100 respectively. Presently, he's on metformin 1000 milligram twice a day, lisinopril 40 milligram once a day, metoprolol 100 milligram once a day, atorvastatin 40 milligram once a day, and aspirin 81 milligram per day. So to just review the patient profile, we have a 58 years old patient with a short duration of diabetes. He does not have any major comorbidities like atherosclerotic cardiovascular disease or major microvascular complication that would really reduce his lifespan. And he's at he's at a low risk of hypoglycemia. But he would definitely benefit if we were to give him a stringent and good glycemic control, and that is going to help him in the long run. And remember, that this patient is obese, hypertensive, hyperlipidemia, and has got obstructive sleep apnea syndrome, which are the associated risk factors for atherosclerotic cardiovascular disease and other development of other comorbidities and complications. As far as the ADA is concerned, it suggests that we should try and achieve a glycemic control target of HbA1c less than 7% in most of the non-pregnant adults. And so when we are going to choose a drug, in addition to efficacy, we should the other considerations which should be kept in mind for determining a pharmacological agent is the risk of hypoglycemia to the patient, weight loss or minimizing the weight gain with the agent, whether the patient has heart failure, CKD, atherosclerotic cardiovascular disease, and again, last but not the least, cost of the agent that has to be kept in mind. So this patient of ours is willing to take another medication, but his concern is that he generally tends to forget to take the medicine, and he's afraid that if he's given too many pills, he's likely this missing the tablets is going to be a bigger problem. So he wants that he should not be given too many pills. And he refuses to go on injectable therapy. And so, in such a situation, I think a fixed dose combination would be a good idea, which may improve the adherence, compliance of the patient, because it is to be given once in a day, and probably if it is to be given, especially if it is to be given once in a day. So, lesser complex the treatment regime, fewer the pills, and improved side effects, they improve the patient's adherence and overall outcome. So, as we all know, that people with type 2 diabetes have commonly have associated multiple comorbidities like atherosclerotic cardiovascular disease, hypertension, heart failure, CKD, and all of them. So all these problems cannot be managed with a monotherapy. And as it is, if you're using a monotherapy, it is not going to give you a sustained good glycemic control over time. So the current guidelines suggest that we should encourage early adoption of oral combination therapies while simultaneously emphasizing the importance of individualizing the treatment. So the ADA suggests that in an appropriate high-risk individual for atherosclerotic cardiovascular disease with established type 2 diabetes, the decision to treat with a GLP-1 receptor agonist or SGLT2 inhibitor should be taken keeping in mind to reduce the 3-point MACE, major adverse cardiovascular events, hospitalized for heart failure, cardiovascular death, and CKD progression. These should be considered independently of the baseline HbA1c or individualized HbA1c target. So we should not be only glucocentric in our focus of managing a diabetes. We should keep in mind the other risks and the associated comorbidity which the patient has. If a patient has atherosclerotic cardiovascular disease, the GLP-1 receptor agonist definitely would get a priority. But if the patient refuses to take injectable, then we have SGLT2 inhibitor to support that, and also DP4 inhibitor if need be. So why we insist that the SGLT2 inhibitors can be helpful, because especially a combination of empagliflozin and linagliptin, we have this combination available with us. This is, I would say, the first-in-class treatment in combination groups of drugs, because the fixed-dose combination of EMPA-LINA is going to be very useful. That SGLT2 inhibitor is a class of novel agents, oral glucose lowering agents. They mediate glucose lowering by action by increasing the urinary glucose excretion, by inhibition of the sodium glucose co-transporter 2 in the proximal tubule of the kidney. And with this has a salutary effect, lowering it acts by independent of insulin secretion and action, and render it suitable to administer at any stage of the disease in a diabetic patient. On the other hand, the DPP4 inhibitor exerts its glucose lowering effect by increasing the incretin hormone levels, and as a result, there is a subsequent augmentation of the glucose-dependent insulin secretion, and there is inhibition of the glucagon secretion, which in a diabetic is inappropriately increased. So it targets both the decreased insulin levels and the increased glucagon level. So the combination of these two agents, that empagliflozin and linagliptin, has a potential to show an additive glycemic load control because of their complementary effects. We have enough evidence for, as far as the empagliflozin is concerned, the empagliflozin cardiovascular outcome event trial in type 2 diabetic patients, the so commonly mentioned as EMPA-REG outcome trial, it has reported that the 3-point MACE outcome occurred in a significantly lower number of patients. There was a 14% reduction in the risk of 3-point MACE in patients who are on empagliflozin compared to those who were on the placebo, along with standard care of diabetes. And so this drug was the first to show that the SGLT2 inhibitors have this, they improve decrease the 3-point MACE, decrease the cardiovascular mortality, decrease the all-cause mortality, decrease the hospitalized for heart failure, and also it slowed down the progression of the renal condition deterioration. So on the other hand, the linagliptin again is a DP4 inhibitor, which has enough evidence from the two trials, Carmelina and Carolina, that cardiovascular safety has been established in these two trials, and also they do not increase the hospitalization for heart failure as shown with the other DP4 inhibitor, the sexagliptin, and to some extent with elogliptin as well. So if added to patients who have been not controlled on metformin, the HbA1c is decreased with the addition of EMPA-LINA 25/5 has demonstrated a 1.81 reduction in HbA1c in patients who have a baseline HbA1c more than 8.5 over a period of 24 weeks. And not only that, this glucose lowering effect is well sustained and maintained at week 52 in this as an add-on to metformin treated group. And a much higher percentage of patients is able to achieve a target of less than 7% reported by with this combination add-on to the metformin group. So this the combination offers a suitable component in strategy to achieve target HbA1c without increase in hypoglycemia, without any weight gain. Rather, there can be some weight loss also with the SGLT2 inhibitor. And overall, lipid profile is improved. There is a reduction in as far as the risk of genital infection is concerned. When the DP4 inhibitor and the HbA1c inhibitor, that is EMPA-LINA, are used together, there is a lesser incidence of the genital infection. This is possibly because of there is better glucose control, or the DP4 enzyme in some of the fungi is inhibited further by the DP4 inhibitors. So as a result, the combination is good for cardiovascular outcome. As far as the empagliflozin is concerned, and linagliptin is safe as far as the cardiovascular outcome is concerned. And both of them are beneficial as far as the renal outcome is concerned. So in summary, EMPA-LINA combination provides robust HbA1c reduction and 2 to 4 times higher odds of patient reaching the goal HbA1c compared to individual agents with low risk of hypoglycemia, low risk of weight gain, and better cardiovascular and renal outcome. Thank you very much.